So good afternoon. My name is Alberto Simoncini. I will give a lecture today about MSK Ultrasound. So these are the objectives of the presentation. We will discuss the role of MSK Ultrasound. We will check the capabilities and limitations, and we will see some common abnormalities. So we use ultrasound to evaluate all these structures that we will see one by one. Let's start with tendons. And one common problem with the tendons is the tendinosis, that is the degeneration of the tendon. In this example, I flipped this MRI. You can see here the distal humerus and the radius. Here you see the common extensor tendon. On the normal ultrasound, this is a normal MRI, right? In this normal ultrasound, you can see the same structures. You can see the radial head and the joint space, the radial head, the joint space, and the lateral epicondyle here. This structure is the common extensor tendon, as you can see here. The common extensor tendon in this case is normal with a normal fibrillar pattern, but in this case you see this focal hypoechoic area that represents tendinosis. There is mucoid material there, there is thickening of the tendon. This tendinosis of the common extensor tendon is also known as lateral epicondylitis or tennis elbow. On this old MRI, you can see the same. You can see the common extensor tendon and this hyperintense area at the attachment site. In the ultrasound of the same patient, you can see the radial head, the capitellum, and the lateral epicondyle, and the common extensor tendon is coming there with this focal hypoechogenic area that represent tendinosis and degeneration. There are different types of tendinosis. The most common ones are hypoxic or mucoid degeneration. With ultrasound, we can also see tenosynovitis. So tenosynovitis is the inflammation of the tendon and the tendon sheath. This is a posterior tibialis tendon in the longitudinal view. You see the tendon as a tube formed by hyperechogenic lines. And around the tendon, you can see fluid as this anechoic area, and you also see thickening of the tendon sheath. This is a normal posterior tibialis tendon. As you can see, there is no fluid around the tendon, and you cannot recognize well the tendon sheath, and of course there is no synovial thickening. In the short axis view on the same patient, this hyperechogenic structure is the medial malleolus. This is the posterior tibialis tendon, and this is the flexor digitorum. These tendons should be ovoid structures, and you see that this is a kind of round structure, it's thick. You see fluid around the tendon, and you also see thickening of the tendon sheath. Ultrasound is a dynamic exam, and we have to take advantage of that. So in this patient with trigger finger, we will check this area. This is the FDS, flexor digitorum superficialis, and this is the FDP, attaching at the distal phalanx. This area is called chiasma of Camper, and is where the FDS splits and let the FDP go through to attach at the distal phalanx. So let's see this movie here in the short axis view. So we are in the short axis view here, maybe at this level. So you can see FDS and FDP. You can see here FDS and FDP. And you have all this black structure around the tendons that is fluid. In this case, you can see here the metacarpal. You can see the interosseous muscles here. These are lumbrical muscles. This is the digital artery, and this is the digital nerve. So we are going distal in the short axis view, and you will see at the area of the chiasma of Camper that the FDS start splitting in two. So now we are at this level, and you have the FDS and FDP going through the chiasma. There is swelling here, the tendon is thick, and there is fluid in the tendon sheath. Now I am distal, I'm going back proximal at the metacarpal level, and I will perform a sagittal view. You have here the MCP joint, a small amount of fluid in the joint. This is the metacarpal in a long axis view. FDS and FDP, as you can see here, FDS and FDP. There is fluid around the tendons. And now I will start with passive motion. And you can see that the FDS moves freely, but the FDP gets stuck in the tendon sheath because there is no room for the tendon. That's why the patient has this trigger finger. The MRI of the same patient shows the fluid in the tendon sheath and the thickening of the tendons. Color Doppler is also useful because in tenosynovitis you may see the synovial proliferation around the tendons, as you can see in this case. You see all this hyper echogenic structure around the tendons with flow representing synovial proliferation. With ultrasound, we can also aspirate a small pocket of fluid. In this case, this is the fourth extensor compartment. This tendon is the EDC, and you have all the extensor tendons for the fingers. In the sagittal view, this is distal and this is proximal. You can see here the lunate, the capitate. This is the radiocarpal recess. This is the midcarpal recess. This is the fourth extensor compartment with the tendons, and we are guiding a needle to aspirate fluid to analyze the fluid. We can also see tears. This is the proximal phalanx of the thumb, and you can see here the FPL, and you can see in this area in the longitudinal view the tendon stump. Sometimes in the finger, this is common in the fingers, you have a fibrous tissue, a lot of fibrous tissue, and you will see some fibrous tissue interposed in the gap and may simulate a normal tendon, like in this case. So this is sagittal view. You can see here the proximal phalanx, PIP, middle phalanx, DIP, and distal phalanx. This is the FDP coming there. Appears in continuity, right? But it's too close to the bone. This is the normal side, and you can see here the FDS, PIP, DIP, and the FDP attaching the distal phalanx. So let's see the dynamic exam. First, in the normal side, you can see in the volar side, the FDP is pulling the distal phalanx, is moving normal. But in the abnormal side, you can see that there is no motion, right? Because here there is a tear and there is fibrous tissue in the tear, but the tendon is not moving. Motion can, or passive maneuvers can help us to localize the tendon stump. This is another FPL. You can see the tendon here, and you see the tendon stump there. What we do is, before surgery, we go there with the ultrasound and we mark the area where the tendon stump or tendon stumps are. In this case, the patient had the laceration here in the hand, and this is the proximal stump, and this is the distal stump. The thumb was in flexion when the patient had the laceration. That's why you see the retraction of the distal portion of the stump. Usually when you have a laceration of the tendon, the muscular portion, the proximal portion, is the one that is retracted. The hand surgeons love this because they just go there, open the area, and repair the tendon. Sometimes we can see partial lacerations. This is a sagittal view of the ECU, extensor carpi ulnaris. This is the tendon here that you can see it in like a tubular structure attaching at the base of the fifth metacarpal. In this case, you can see the laceration involving the subcutaneous tissue and extending to the most superficial part of the tendon. So this patient had no mechanical deficit because part of the tendon was intact. We can see also avulsions. Let's see this case. MRI, this is the patella. This is the patella on ultrasound. I tilted the MRI. So you can see the anterior tibial tuberosity, and you can see the wavy appearance of the patellar tendon. And here on the ultrasound, you can see again the wavy appearance of the patellar tendon. When the tendon has this wavy shape, the sound is refracted in different directions, and you will see acoustic shadowing. And this is very important to make the diagnosis of tendon and nerve tears. In this case, at the stump, you can see this hyperechogenic line that represents an avulsion fragment of the inferior patellar pole. This is an MRI of the elbow performing FABS position, that is flexion, abduction, and supination. That is the position that we use to check for distal biceps tendon tears. And you can see here the brachialis with the normal attachment at the ulna. This is the biceps tendon, and this is the wavy appearance of the, so this is the biceps muscle, and this is the wavy appearance of the biceps tendon. This tendon should attach here at the bicipital tuberosity. In the sagittal view of this MRI, you can see the biceps here and the wavy appearance of the biceps tendon. This tendon should attach at the bicipital tuberosity. With ultrasound, we see the same. We can see the brachialis in the sagittal view, and we see the tendon stump in the long axis view. Here, we are measuring the distance from the stump, that is here, to the bicipital tuberosity. So the surgeon can go there and reattach the tendon at the bicipital tuberosity. Dislocations, the most common dislocations of tendons that we see are the peroneal tendons and the biceps tendon. So this is a short axis view of the bicipital groove. You can see here the lesser tuberosity, the greater tuberosity, and this ovoid structure is the biceps tendon. This triangular structure here is the subscapularis in long axis view. This is like an axial of MRI. And you can see these white fibers here. This is the transverse humeral ligament that it comes from the subscapularis and fixes the tendon in the bicipital groove. The main stabilizers of the biceps tendon are the superior glenohumeral ligament and the coracohumeral ligament. And the transverse humeral ligament also helps to keep the tendon in the bicipital groove. When you have a tear or when you have a dislocation of the biceps, if the subscapularis is intact, you will see the biceps displaced medially superficial to the subscapularis. But since dislocations of the biceps are usually associated with subscapularis tear, you may see the tendon, the biceps tendon, in the substance of the subscapularis, or it could be below the subscapularis. In this case, we see the normal biceps tendon in the bicipital groove, and here we have an empty bicipital groove, and the tendon is dislocated medially. There are tumors associated with tendons, and the most common one is the ganglion cyst. There is a very common location that is close to the radial artery in the wrist. And so we can use Doppler to demonstrate the relationship with the artery. You can see here the artery, and you can see the cyst. Other common location in the wrist is the superficial to the scapholunate joint. So whenever we see a cyst, we always want to use Doppler. This is the same location. This cystic lesion was close to the radial artery, but the patient was a pediatric patient. It's not very common to see ganglion cyst in pediatric patients. So we use Doppler, and with Doppler you can see the yin-yang appearance of the pseudoaneurysm. The most common solid tumor adjacent to the tendon is the giant cell tumor. The new name for giant cell tumor is pigmented bilionodular tenosynovitis. In this case, you can see the flexor tendon here. This is the metacarpal, and you see the solid mass. I reported this as a probably giant cell tumor, and pathology came as a hemangioma, which is another common solid tumor adjacent to the tendons. We use ultrasound to evaluate for muscle trauma. Muscle trauma could be direct or indirect. We can check for fibrosis, or we can check for hernias. So let's see this sagittal ultrasound of the anterior thigh. You can see here the rectus femoris, and this is the vastus intermedius. And you can see this huge hematoma in the muscle. When you have a direct trauma, the affected muscle is the one that is closest to the bone. In this case the vastus intermedius. So you can see this big hematoma, or you might see a lot of edema with small hematomas, as you can see in this patient. And as you can see on this ultrasound, you see in the short axis view heterogeneity of the fibers, and you see very small hematomas. Indirect trauma is common in biarticular muscles that have fast fibers, and one common place is the distal biceps. And the tear is usually there, and it is just after the sprint. And we will see, we call this this muscle, the biceps, has two portions. So one portion is biarticular, that is the long head, and the other one is monoarticular. So the long head comes from the ischium, so goes through the hip and through the knee. The short head goes through the knee. They have a different pattern of fibers. These fibers are coming this way, and they have a converging type of distribution, and they attach to this, that is the distal tendon that goes to the fibular head. They also have different innervation. The long head, the innervation of the long head comes from tibial nerves, from tibial branches of the sciatic nerve, and the short head comes from the peroneal fibers of the sciatic nerve. Okay, so we will see the tear here. The tears in the indirect trauma are close to the myotendinous junction. So we will see the tear here. So let's review the anatomy. So we have here the short head of the biceps, the long head of the biceps, and this is the biceps tendon. These are the fibers that should reach the tendon, and they are torn and retracted. Okay, so the tear is just there. With ultrasound, we can also see fibrosis. Look at this MRI comparative. This is the indirect tendon of the rectus femoris. which is normal, and in this case we have is thick and black, right? It's thicker than the other one, and this is because of fibrosis. But this is very difficult to diagnose if you don't have the contralateral one. With ultrasound, you can see the rectus femoris in the normal side and in the abnormal side. This is the indirect tendon, and on the other side you see this focal hyperechogenic area with retraction of the aponeurosis. Look at the aponeurosis. Here is convex and here is concave because there is retraction due to the fibrosis. This patient came to our office because the patient had soft tissue mass at this level. Static ultrasound was normal, but dynamic ultrasound shows this herniation of the anterior tibialis muscle through the aponeurosis. You see the muscle fibers here are coming there, and you see this defect in the aponeurosis. So this is a muscle hernia. On the static exam with contraction, you can see the aponeurosis here, the aponeurosis there, and the defect in the muscle. We can check some ligaments with ultrasound. Some superficial ligaments are well visualized with ultrasound. Of course, we cannot see the ACL, PCL, but we can check for this ligament that is the ulnar collateral ligament of the first MCP joint, and you see the hyperabduction of this thumb. So we are going to check for this ligament. It's the ulnar collateral ligament of the MCP joint. So in this case, there is a tear. This is called skier thumb, when there is a tear of the ligament. And when the tendon is, or ligament, sorry, is retracted under the aponeurosis of the adductor muscle, you will see the sterner lesion. So in this case, you can see there is a tear here, and here there is a tear and there is retraction, right? The same in this MRI. You have a tear here and there is retraction. On the ultrasound, you can see the normal side. This is the metacarpal head, the proximal phalanx, and you see the ligament there. In this case, you can see the metacarpal, the proximal phalanx, and you see a mass here, and this mass represents the ligament that is retracted proximally. So this is called sterner lesion. And it's important to diagnose this because if you have a sterner lesion, the patient needs surgery. We can check the joint cavity for fluid, synovial proliferation, or interarticular bodies. This is the suprapatellar recess of the knee, and you can see fluid here, and you can see synovial proliferation in the sagittal view. Again, Doppler can show us the flow in the synovial proliferation. Ultrasound palpation can help because you can think that this structure is debris or maybe synovial proliferation. When you perform palpation, you see that this is a front-like structure coming from the posterior aspect of the synovium. This patient has swelling and locking of the thumb MCP joint, and we are placing the ultrasound probe at this level. So you will see the metacarpal head and the proximal phalanx. When we perform the ultrasound, we saw the metacarpal head and the proximal phalanx, and at the joint space we saw this hyperechogenic structure with acoustic shadowing. The differential diagnosis was calcific periarthritis or calcific periarthritis or interarticular bodies. So we did the dynamic exam, and you can see here the structure. We perform abduction of the thumb, and you see this structure is almost going into the joint. So we tried a little bit harder, and we have our structure here, hyperechogenic structure, and we push a little bit the phalanx, and we saw that this thing was moving freely and going into the joint. Then we push a little bit more to explain the symptoms that we're looking, and you can see that the structure disappears completely in the joint. So this is not calcific periarthritis. This is an interarticular, and this is a true loose body that was locking the joint. See here, the structure falling into the joint. So this is the structure on plain film is here in the joint, and they remove it. So one thing that we can check with ultrasound is in patients with gout, we check this double contrast sign that is very specific and is sensitive to diagnose gout. So let's see the anatomy here. This is the metacarpal. Here, this is the volar plate. This is the flexor tendon, and this is the articular recess. The blue line is the cartilage. So let's go here in the normal side. You can see the metacarpal head. You can see the cartilage, hyaline cartilage, and you can see the volar plate, which is fibrocartilage. Then you can see the FDS and the FDP. In the patients with gout, you have superficial deposition of crystals. So you will see a white line in the surface of the cartilage. And in this case, in this patient with gout, you can see the cortex of the metacarpal head, the hyaline cartilage, and then you can see the crystal deposition. And this is called double contour sign, which is very specific for gout. And on CPPD, on the other hand, you have the crystal deposition intrasubstance. So in this patient with a tibial fracture, you can see the crystal deposition of CPPD intrasubstance, and not in the surface as we see in gout. We can check nerves with ultrasound. We can check for nerve entrapment. We can check for trauma, for pseudotumors, or for tumors. So one of the most common indications in nerve entrapment is the carpal tunnel syndrome. We don't do nerve conduction studies anymore in this institution. We manage all the carpal tunnel syndromes with ultrasound. So let me show you the anatomy. Here you have the pisiform bone there, pisiform. This is a short, a transverse view of the wrist. This is the scaphoid here, scaphoid. This is the canal of Guyon with the ulnar artery and the ulnar nerve. You can see them here, ulnar artery and ulnar nerve. This is the median nerve, and this line here is the carpal ligament. So what we do for carpal tunnel syndrome, we measure the cross-sectional area of the median nerve at the carpal tunnel inlet, and we consider 10 square millimeters as normal, because usually you have a pre-stenosis dilation of the nerve. So look at here in this sagittal view, you can see very well the dilation, the pre-stenosis dilation of the nerve. This is the FDP, FDS, this is the median nerve, and the carpal ligament is located at this level, and that's why you see this swelling of the nerve proximally. So we go there and we measure the cross-sectional area. We can use ultrasound to evaluate nerve trauma for the acute nerve trauma or in the post-surgical cases. So we check with ultrasound for nerve laceration, for fractures, or for dislocations. So stretch injury in dislocations or nerve injury in fracture. So this is a median nerve laceration, and you can see here the proximal stump, sorry, the distal stump, the proximal stump. You see the laceration, and you see this black mass here. This is called an amputation neuroma. This nerve is trying to repair itself, and since the fibers cannot reach the distal portion of the nerve, form this pseudotumor that is an amputation neuroma. We can see very small, very thin nerves. This is a digital nerve, common digital nerve at this level. It's a branch of the median nerve. And you can see this nerve coming here. And you can see this focal hypoechogenic area due to partial laceration of the nerve. In this case, you have a gunshot wound injury with severe shortening of the humerus and multiple pellets. So the patient has deficit in the radial, ulnar, and median nerve, and we explore all these three nerves. We found that there was swelling of the radial nerve, but the nerve was intact with no discontinuity. The median nerve was swollen too, and we found a lot of foreign bodies intrasubstance that are these hyperechogenic structures. Of course, this is the longitudinal view, and this is the short axis view. And you can see the swelling, the heterogeneity, and the foreign bodies. But there was no discontinuity of the nerve. And look at what happened with the ulnar nerve. Look at the wavy appearance of the ulnar nerve due to the shortening of the humerus, but there was no nerve discontinuity. In humeral fractures, the radial nerve may be entrapped in the spiral groove. This is a picture from radiographic, and you can see here the radial nerve that comes there, and at the level of the elbow, you will see two branches, the sensory branch and the motor branch, that is the posterior interosseous nerve. So in this case, we are looking for entrapment at this level. We can see it after trauma, or we can see it after plate and screw fixation. When the surgeon put the plate, sometimes they may entrap the nerve between the humerus and the plate. In this case, we have this short axis view. You can see a bony fragment here, a bony fragment there. This is the fracture gap, and you can see this nerve that is entrapped in the fracture. This is, in this case, the ordering physician asked us to check for the distal radial nerve, the sensory branch. The sensory branch of the radial nerve is pretty thick, easy to find the branch. And I was there like 10 minutes trying to find the nerve, and I couldn't find it. So I had to tell the patient, sorry, I cannot find your nerve. And the patient showed me a picture from his iPhone, and he showed me this. This patient had, he was bitten by a dog at the level of the wrist. And the sensory branch was avulsed from the elbow. So at the level of the bifurcation, I told you that the radial nerve splits in two branches, the motor branch and the superficial branch. So when the dog pulled the nerve under the skin to the level of the elbow. And then the resident went there and cut the nerve, and that's why I couldn't find the radial nerve. In the post reattachment status, we check for nerve continuity, we check for neuroma in continuity, and we check for fibrosis around the nerves. In this is what you want to see. In this ulnar nerve, you can see the nerve coming here, the nerve there, and this small amount of suture material in the nerve. You don't want to have too much suture material because you may produce fibrosis and you may limit the nerve regeneration. In this case, this is a digital nerve. This is a sagittal view of the nerve coming there. This is post-surgical, and I found this small neuroma here, and there was discontinuity, and then distally we found the distal portion of the nerve coming there. So with these modern ultrasound machines, we can check for very thin nerves. Look at this. This nerve is just 0.3 millimeters. So it's the third part of a millimeter. One French? Okay, one French. Okay, so this is very thin. This is a very thin structure. Again, after surgery, it's common to see this neuroma in continuity. So you have the nerve here, and you see this mass that is called neuroma in continuity. Again, in spite of being surgically repaired, the nerve is not, the nerve formed this neuroma, and as you can see here, it is displacing all the suture material. See, in the short axis view, you have the mass here, and all the suture material is displaced superficially. So this is neuroma in continuity. We can check for tumors originating in the nerve tendon sheath. As you can see here, when you see an ovoid mass in a neurovascular bundle with an afferent nerve and an efferent nerve, you can say that this is a nerve sheath tumor. These tumors may be solid, or in case if they are Anthony B, they have myxoid material and they can look like a cyst. We can also check for pseudo tumors, like the motor neuroma. So you can see here the digital nerves. These are the metacarpal heads, and these are the intermetatarsal ligaments. So if you use high heels, this transverse metatarsal ligament may irritate the nerve by compression, and you may have fibrous tissue and this mass that is called motor neuroma. So we can see it here between the head of the third and fourth metatarsal, and you can see this solid mass here and this solid mass at this level. So the differential diagnosis of forefoot pain is usually stress fracture, intermetatarsal bursitis, or motor neuroma. If you see a solid mass, it's motor neuroma, and if you see a fluid lesion, it's probably intermetatarsal bursitis. We can check for bursas. In this case, we have fluid and synovial proliferation in the subacromial subdator bursa. You can check for the olecranon bursa, as in this case. You see the synovial proliferation in the olecranon bursa. You can see fluid in the retrocalcaneal bursa here, or calcaneus subcutaneous bursa there. This is the long axis view. You can see the Achilles tendon here attaching to the calcaneus, and you can see fluid and synovial proliferation in the retrocalcaneal bursa. This bursa is the one that produces the erosions in rheumatoid arthritis and psoriatic arthritis. Prepatellar bursa is prepatellar bursitis is the most common one. You have to be careful because you can compress with the probe and fluid will disappear and may be difficult to find. We can check, we can evaluate the fascias, for example, the plantar fascia. This is a sagittal view of a normal MRI. The black line is the plantar fascia attaching to the medial tuberosity of the calcaneus. On this normal MRI, you can see the plantar fascia coming here and attaching to the calcaneus. Plantar fasciitis is usually at the attachment site. If you have a mass at this level, distally, usually with no pain, is plantar fibromatosis. If you have thickening of the plantar fascia, is plantar fasciitis. In this tennis player, you can see the plantar fascia coming here, and you see thickening and abnormal signal intensity at the attachment site. The ultrasound shows the plantar fascia coming there and thickening of the plantar fascia at the attachment site. The comparative exam shows the normal side that measures usually less than 3.5 millimeters, and in the abnormal side you can see that the lesion or the thickness is 7.6 millimeters. So there is thickening of the plantar fascia. We can evaluate soft tissue tumors with ultrasound. Mainly, first, I would say that the first indication is to discriminate tumor from pseudotumor. This patient had a palpable mass on the anterior thigh, and this mass is cystic and solid. We use color Doppler, and you can see the superficial femoral artery, deep femoral artery, and you can see this yin-yang appearance of the pseudoaneurysm. You can check for foreign bodies too that may present as a palpable mass. In this case, you have a wooden foreign body, and you have this granuloma that is common to see around the foreign body. With Doppler, these granulomas may show hyperemia. In this case, this patient has osteomyelitis of the 4th and 5th metacarpals, and they requested the ultrasound to check for fluid collections. And when we went there, we found this foreign body going through the bone with this foreign body granuloma reaction, or maybe an abscess around the foreign body. We can check for fractures. This is a normal metacarpal in a pediatric patient, and in this patient with a green stick fracture, we can see the surface of the bone and we can see the fracture. We can check for erosions in patients with rheumatoid arthritis or in patients with gout, and you want to see focal discontinuity of the cortex in two planes, in the sagittal view and in the short axis view. This is the metacarpal head, and you can see here the cortex and this discontinuity of the cortex. In this case, you can see the cortex, the discontinuity, and then the cortex again. Whenever you have an erosion, you may have this acoustic enhancement posterior to the erosion. So ultrasound is a useful tool to evaluate and diagnose many MSK conditions. It has a lower cost than MRI. It has better availability, portability, better acceptance by the patient. It has no contraindications. I show you the real-time capability. It has better spatial resolution than MRI, but that doesn't mean too much because MRI has better contrast resolution than ultrasound. And ultrasound can guide interventions. The disadvantages of ultrasound are that it's difficult to read just from static image, cannot evaluate some structures, is time consuming, it has low reimbursement levels, is operator dependent, and it has a relatively long learning curve. Thank you very much. I don't know if you have any question. No question. New Orleans, any question?